Yeah. So at this particular talk, I don't have any relevant disclosure. If you go look back the data of aortic valve in valve outcomes, it has been always fantastic. And why it is coming up so well? Because if you look at the US data, the last century, only 33% of the surgical valve implanted were bioprosthetic. But just 10 years after, it has raised to the nearly more than 60-65%. So more the bioprosthetic implantation being there in the practice, more the chances of valve in all procedures will be there in the routine practice. And how this echo helps? Echo does not replace the CT, but it's complementing the CT. And for the better planning of the CT, if you have the good 3D TE before the sending them for the CT, it really helps. So primarily the most important thing is general examinations where we have to check for the right ventricle function assessment. More the RV dysfunction, patient has got more chances to get into the issues. So RV function assessment, pulmonary hypertension, other valves, sizes of the ventricles, chambers and the atrial chambers are very, very important. It plays a very significant role. Specific spacing, Dr. Ahmed says very nicely narrated the effect of the previous valve type, whether stented or stentless, or the size and the depth. But most important thing is when we on echocardiography we have realized that when they have the stentless valve, it is difficult to differentiate whether the patient had got previously surgical AVR or not. So the stentless valve, when they come for the pre-operative echo examinations, it is sometimes difficult to differentiate, unlike the stented valve, and the chances of coronary obstructions are very, very high. So if we want to evaluate the preoperative assessments, in that case, the important aspect is to look for the calcification of the valve and degeneration of the valve and the size of the LV, the previously valve. That is very important. Along with that, from where the regurgitation is and what is the condition of the other valve, whether it is a degenerative other valves like MR, if patient has AVR with MR, AR, MR, TR, severe PH, and we should really address all the valves rather than doing only the valve-in-valve procedure. So LVOT area plays a very important role because previously it was operated for the surgical valve, and we have to see that how the patient had regurgitation at which area, how is the calcifications. By implanting the balloon this time it may rupture. LVOT area plays a very important role, even though there may be some septal hypertrophy also, that is called the basal septal hypertrophy. And this basal septal hypertrophy plays a very important role that when you are inflating it, that is called the septal bulge. So septal bulge part has to be also ruled out in case of the parts in a tower. So important LVOT area assessment plays a very important role. Along with the endocarditis, previously patient had any vegetations or not. And you can see in the 3D TE, this is the orifice of the left coronary artery and this is a bioprosthetic aortic valve. So we need to, like previous speaker, Dr. Hamid said very nicely about the impact of the coronary artery positions. So how it is away from the bioprosthetic aortic valve plays very important role. Otherwise, as he said, we have done many basilica procedure, what he has explained that. So we just rupture this part of the coronary cusp by inflating the balloon, and we just see that how the coronary artery flows very well. So the pre-operative assessment of the coronary artery flow also plays very important, and the distance from the aorta to the coronary artery also is very important. So two most important determinants: patients with stenosis as the mode of failure, and the valve size is less than 21 millimeter. If patient has degenerated aortic stenosis, is more dangerous than patient comes with aortic regurgitation or leaflet tear. So the stenosis and less than 21 millimeter size is very important, and that is something called the Matryoshka effect, that if a smaller size, if you put further smaller size of the valve, then the patients have 70% chances that hemodynamic improvement will not be there. So the ideal size of the valve is very important, because if you know that the Edwards 21 size is equal to 19 millimeter internal diameter and Hancock 21 is equal to 17 millimeter internal diameter. So we should not go to the label of a diameter, but we want to go to a real actual diameter. Otherwise, patient comes with a patient prosthetic mismatch, and it is said that when the patient has 0.65 centimeters square per meter square of the less than 30 BMI, or 0.5 centimeters square plus meter square of more than 30 BMI, if effective orifice area, these are the patient who is not going to get benefited unless and until they go for the aortic root enlargement. So these patients are not good patients for the valve-in-valve. So this is how we just measure intra or pre-operative also all the distance what were measured into the CT scan by our multiplanar reconstruction. We do it routinely because we do many cases with the zero contrast TAVI. So in zero contrast, we have to be exactly shown the same thing what CT is done with the 15% just variation. Here you can see that the aortic wall area was 3.37 and here it is 3.4 centimeters square. So it is almost nearly the same what we can go to. So all these parameters, when you have a doubt about the coronary artery issues, about the size of the annulus, then these are the important elements. So only just a minute. Where is the timer? Okay.
You have 2 minutes, Doc.
Yeah, so just within 2 minutes, I'll just touch some important aspect of the TMVR, wall-in-wall for the mitral valve. Important aspect is look for the thrombus and the septum. These are the two important aspects to be seen, whether the intra-arterial septal hypertrophy is there or not, thrombus is there or not, or the previously patient operated for the mitral valve through the transseptal. So this septum becomes so thick, so it is difficult to perforate unless they do the cauterizations through the transcatheter interventions. So it is very important to evaluate complete septums when we talk about TMVR, along with the presence of any foreign bodies into the left atrium. So this is how we look for the right atrium. You can see that this is the aorta, so this is anterior, posterior, this is superior and inferior. Sometimes they may have the large ASD or part of the ASD which was left alone of previous cases, that also be clearly mentioned. And these patients usually they puncture. Usually they puncture at these level, that is mid to superior aspect and little posterior aspects. So this is exactly site of the puncture which has to be shown. So previous pre-operative patient has to be done with the 3D TE in both the wall-in-wall cases, that we just give them exactly idea where they are going to the puncture. And this is how they are going to check it. Most important aspect about these sizes, like this is what is the septo-posterior distance. And in this distance, if you measure the distance from here to the bioprosthetic mitral valve, it should be more than 3.5 centimeters. Otherwise, they will not able to flex the mitral valve correctly. If you do the mitral clips, it should be about 4 and 4.5. But in case of the bioprosthetic mitral valve, at least this much distance, the distance from where the septum is punctured to the level of bioprosthetic mitral valve, it should be at least 3.5 centimeters. So these things has to be given up. Once everything is clear by this, by looking at the PPM, the patient prosthetic mismatch, septum, coronary artery evaluations, other valves, other pathology, then only we can shift the patient for the further evaluation of the CT. Here, like AVR, LVOT is also plays very important role. Otherwise, particularly when we are talking about TMVR, anterior mitral leaflet calcifications, or that area also plays a very important role, because once they inflate the balloon valve, then the chances of these inflated calcific valve can obstruct into the LVOT, and then we have to do the lampoon procedure that we did couple of times here, that we just inflate it and rupture the anterior mitral leaflets. So when whether we talk about the AVR or TMVR or TAVI, in wall, LVOT assessment plays a very important role by looking at the calcifications, looking at the septal bulge, looking at the anterior mitral leaflet, looking at the calcification of anterior mitral, everything very important. So to conclude is, transesophageal echocardiography with the 3D assessment is not replacing CT, but yes, when patient needs zero contrast and we cannot shift the patient for the CT, all the parameters which are available with the CT is available with the multiplanar reconstruction on the echo. We have the 3D workshop followed by. And second important thing is 3D TE aspects plays a very important role, whether we should shift the patient for the CT imaging or should be subjected for the surgery, particularly the aortic root enlargement. Thank you very much for the kind